recording and listen to it again, anyway, so this is being recorded. Okay, that's how we're going to do the next 2 hours, and then you'll be hearing from me. So let's start with introductions, and let me just introduce myself first. My name is Catherine Schrag, and I am both a CNM and an FNP, but most of my clinical practice has been in midwifery. I've been on faculty at Frontier for 13 years, 14 years probably. I was the RCF for the West Southwest for women's health and midwifery for most of that time. About a year ago, I decided it was time to retire. And then I kind of got freaked out about retiring and decided I wasn't ready to completely retire. So I decided I would semi-retire, and Frontier said, well, why don't you just quit being an RCF and just teach in this course, which I thought was great because I have always taught in the role courses in addition to being an RCF. I have a personal interest in the business of advanced practice nursing and midwifery. Way back in 1982, I started a freestanding birth center, and I ran it for 20 years. So I'm one of those strange people that likes both the clinical practice and the business piece. So I like teaching in this course. So that's what I'm doing. And I will tell you after you do your presentations and we regroup, I'll tell you just a little bit about my experience, running a practice. The other thing I should say is that I also teach very part-time for the American Association of Birth Centers. They do a workshop called How to Start a Birth Center. And I teach, I'm the lead faculty for that, and I teach half of those workshops. And all the CNEP students have to take that workshop. So I may have met some of you. I mean, you may have listened to me for 2 full days. Yeah, see, somebody's met me. All right. Nice to see you again. So that's the other hat that I wear. But I really am semi-retired, and I'm sitting here in southern Arizona. I live about 15 miles from the border of Mexico, and in a beautiful little town. I love living here. My husband and dog just went out, and I told them not to bother me for the next 2 hours. So that's me. So let's go. Kathy, why don't you unmute? And for these introduction parts, let's just unmute as we go along in the presentations. Then, usually the Google Hangouts Live work well enough that with 6 or 7 people, we can all stay unmuted for the second half and actually talk some. So, but anyway, so Kathy, why don't you introduce yourself?
Thank you, Catherine. My name's Kathy Iorillo, and I'm a retread to Frontier as of about 6 weeks ago. So I'm very, very familiar with Frontier, even though everything's different. So, and I'm new to this course. So I'm going to be hosting my first Disruptive Innovation session on Friday. So I've been just hanging out with different faculty, just getting the lay of the land and what the expectation is during the assignment. And like Catherine, I have 15 years experience as a nurse midwife and 7 years experience as a FNP. I did not do my nurse midwifery education at Frontier. I did that in Southern California, but I did my FNP and my DNP at Frontier. I've also been an RCF for Frontier and taught in some courses that are no longer actually active at Frontier. So I have a very long history, and I've worked in a variety of different settings. I wish I had the principles of this course when I was in school, so I kind of had to learn it trial by fire, so to speak. But I've worked in private practices, public health departments, federally qualified health centers. I worked in a retail health environment for CVS Minute Clinic for several years. So I have a lot of various experiences that I think add to my knowledge and my contribution for this course. And I'm really excited about these presentations that you all do. I've seen several of them now, and they're all just great. So I'm going to turn it over. Thank you.
Okay, before you leave, I see green trees. Where are you?
Oh, that's great. Well, I'm kind of living in a couple locations. My home is in the Tampa Bay area of Florida, and I'm also spending a lot of time in Atlanta. So I'm in Atlanta right now.
All right, cool. All
Yeah.
right. So let's just go around and do introductions. And for these introductions, name, where you live, that helps me remember. I don't know. I can remember where people live better than their names. So names, where you live, what program you're in. So we often have there are DNP students in this course that are getting their postmaster's DNP. So if you're a DNP student, let us know what your specialty and work has been, and what your professional work. For the master's students, let us know what program you're in, whether it's FNP, Women's Health, or Midwifery. So just quick introductions. So Anne, we'll start with you.
Okay, hi, I'm Ann Schaefer. I'm in Harrisonburg, Virginia, which is in the Shenandoah Valley. And I am DNP class 24. I was CNAP class 25. And Catherine, I attended one of your birth center workshops. I think it was 1998. So I remember.
Oh my gosh.
It's been a while. So it's, yeah, and actually I wrote a business plan as part of the Birth Center series in my CNAP classes, and I used it to open my first practice as a new graduate from CNAP. So I've been practicing as a midwife for 17 years. For the last 5 years, I've been faculty in an undergraduate BSN program at Eastern Mennonite University here in Harrisonburg. And I left private practice earlier, well, not even a full year ago, to join FQHC. So my presentation today has to do with my role there. So.
All right, well, cool. So you're back for your DNP after all those years.
Yes, indeed.
Well, welcome back.
Thank you so much.
Yeah, you know what? Let me say one other thing. I don't have a DNP or a PhD. Frontier lets me stay because I'm old and I've been around a long time. So I don't have that. And please call me Kathy.
Okay, Kathy.
All right. I mean, no, I'm sorry. Don't call me Kathy. Call me Catherine. Call her Kathy. Call me Catherine.
Okay.
And Kathy will tell us. There's that whole thing about, so once somebody has their doctorate, what do you call them? So, but I think if I had a doctorate, I would still say, call me Catherine, but I'm not sure because I don't have it. So anyway, okay, Brittany.
Alrighty, my name is Brittany Sloan. I live in Charlotte, North Carolina, and I'm an FNP student.
All right. Okay, Brittany. Mary Kate.
My name is Mary Kate Finnegan. I also live in Charlotte, North Carolina. I am an FNP student, and fun news, my sister is currently in labor, and I'm very excited. I'm like watching my phone to see if she gives me any updates. So just a little side note.
Oh my gosh, you're going to be very distracted. No wonder you want me to tell you when you hit 6 minutes.
I'm sorry.
You don't have to apologize. I love that you asked.
A midwife birth in a birth center in Philadelphia, so I'm very excited.
Okay, so you are not on call to run to her birth, though?
That would be impossible.
Okay, all right. So, and I assume you guys know each other because you're both in Charlotte?
We drove to Clinical Bound together, yeah.
Oh, nice.
We met.
Nice.
She saw that I posted in, I guess, one of the forums that I was from Charlotte, that we were going to the same Clinical Bound. So she contacted me, and that's how we met.
Yeah, nothing like being in the car together for 8 hours to get to know somebody, huh?
It helped us study.
Okay, Ashley, where are you and what are you doing?
Hi, I am currently living in Pittsburgh, Pennsylvania, and I am in the CNEP program. So I have 48 hours left in clinicals. So
you're almost done. Congratulations. So did you go to the How to Start a Birth Center workshop in Pittsburgh that I taught?
Mm-hmm. Yeah, so I saw your face and I was like, I know her from somewhere, but I'm not sure where. So
I looked at her face for 2 days. Yeah.
Yeah.
All right. Oh,
I brought my giant baby. I don't know if you remember Harriet.
Oh, you did. Yes. And did you do part of your clinicals at the birth center there or no?
Yeah, I've done actually most of them there. And
are you doing a fellowship when you're done?
I hope so.
You hope so. I think I remember that you were hoping to do that.
Yeah, I don't know yet, but yes, I am hoping so. I love it there. I worked as a nurse for several years there and had my last 2 babies there. So
yeah, it's a very impressive
love it there.
Organization. You're right. Right. Okay. Interesting. All right, Tanaya.
Hello, I'm Tanaya Miriam. I go by Ty. I'm in.
Oh, you go by Ty. Oh, thank you.
much easier than Tanaya. I'm in a little town called Houston, California. It's near Modesto, kind of in the heart of California, and I'm in the CNET program.
Okay, so you're far enough south that we're not worried about the Oroville Dam and your house flooding away.
Yes, I am very far away from that. I'm far enough away.
Yeah. Well, that is really scary. Have you guys all seen on the news about that? I mean, that's intense. Very intense. All right. Okay, and you're in CNEP. So we have a nice representation here. Okay, let me say a few more words and then let's get these presentations done. So let's see, I want to say a couple things. The first thing I want to say is that I want to acknowledge that you have spent a lot of hours preparing your ideas, preparing a budget, and then we ask you to summarize it in 6 minutes, or 7 minutes, up to 7 minutes, and that is challenging. But in real life, I mean, as Anne will tell you, back in the day, they had to write a business proposal that was dozens of pages long. I mean, huge, huge. So this is what this long tradition at Frontier of trying to teach business entrepreneurial implementation skills to our students. And we have a long tradition of doing that. You know, Mary Breckenridge did it. So it's, and at present, the last few years, this is how we have been trying to teach those skills to make it a little less burdensome. And hopefully a little more fun. And you get to learn from each other by hearing each other's presentations as well. And even if none of you think that you're going to someday really open a practice, you don't know. You know, you may. And I would say that particularly in today's unsettled healthcare environment, that we just don't know what's going to happen. And there will be opportunity for leadership in, if not creating a new practice, creating new ways of thinking about things, or a new program within an existing practice, or your practice that somebody hired you may suddenly implode and you're out there looking for something and you have to sell yourself to another practice. So learning the skills of succinctly selling yourself or an idea or both is a skill that we all are going to need in today's healthcare environment. And I think in general, as nurses, as RNs, we're not real good about boasting. And, you know, in general, that you could say that as a generalization. And, you know, as a nurse, generally you just go out and you get a job. You know, as an advanced practice nurse, you're not only selling your clinical skills, but you're selling you as a person. It's a big investment to bring you on, or you're selling an idea that you want somebody else to fund, or you're going to fund it yourself, you know. So this isn't just to graduate. These are skills that are, and principles that I know in some form or another you will use in your real life. Okay, so I guess that's the main thing I want to say. And I think that's enough to say for now. So let's do these first. So Anne, why don't you unmute and pull up your screen share. And then once it's up, I'll let you know that we can hear it or see it. And then you can start whenever you're ready to start. And I have my little timer here. I'm not going to cut you off if you go beyond 7 minutes. You just get some points deducted, you know, so.
All right, so it looks okay from where you guys are?
It looks totally fine.
Okay. All right. Okay, I'm Ann Schaefer, and today I'm going to be discussing obstetric care and centering pregnancy at Harrisonburg Community Health Center, a disruptive innovation. HCHC is a federally qualified health center. We offer multiple service lines and employ over 70 employees. We're in a period of rapid growth. In 2016, we saw over 16,000 client visits, and we are expecting to more than double that into 2017. Our business structure is that we are a not-for-profit 501c3 legal entity. As an FQHC, we get enhanced reimbursement for our Medicaid and Medicare clients, and we have a sliding scale that goes to $10 a visit. We are overseen by a board of directors. In our 2015 HRSA site visit, it was noted that at the time our lack of women's health care and prenatal care was not in line with the expected primary care services. We addressed that by adding women's health in 2016, and adding prenatal care will bring us fully in compliance. Our community is diverse and multicultural. We are a 3-university city located about 2 hours south of Washington, D.C. However, we're very diverse and have some significant health disparities. 27% of adults are uninsured in our area. A quarter of our population is Hispanic and Latino, and we have over 35 languages spoken in our public schools. At HCHC, 45% of our clients do not speak English as their first language, and the pediatricians in our community who are in private practice do not take Medicaid, so we see 40% of all newborns and infants born in the community at our center. In terms of perinatal health, compared to Virginia, our service area has a higher rate of late entry to prenatal care and a higher birth rate to our teens ages 15 to 17. We also have some significant barriers to accessing OB care for underinsured women. The health department has been a point of entry to OB care for these women, but they are phasing that service out. Private practices limit how many underinsured and Medicaid women they wish to take and instead refer women to University of Virginia Hospital, which is 60 miles away with no public transportation. Therefore, 3 significant community needs identified are to increase the rate of first trimester prenatal care, improve continuity and access to obstetric care, and improve our postpartum follow-up and family planning, especially for our teen clients. The proposal, therefore, is to implement an obstetrics program at HCHC that includes prenatal care through 32 to 34 weeks, with referral out to a receptive private practice for labor and birth, offer centering pregnancy, and provide postpartum care with ongoing family planning. With that in mind, the adapted vision and mission of HCHC is that Harrisonburg Community Health Center is a leading nonprofit provider of quality care for all people in our diverse community. Our mission is to improve access to family-centered care with an emphasis on serving those who have previously encountered barriers to care. With the addition of prenatal care, HCHC will become a true family health care home, and we will still have access to local private OBGYN practices, our community hospital at Rockingham Memorial Hospital, and the University of Virginia for our high-risk women. Advanced practice RNs are well prepared to address these identified needs. Research has shown that when insurance status is not a factor, women are more likely to seek early prenatal care. Women value relationship with their providers, an area where APRNs excel, and that is associated with compliance with prenatal care. Lack of prenatal education and information is also a barrier to care seeking, and childbearing women really want contact with other women during pregnancy who speak their language, which is why centering pregnancy in the midwifery model is so ideal. Women who receive prenatal care and centering have been shown in research to be more satisfied with their care, to receive more adequate care, and are more likely to attend their 6-week postpartum exam. And even a year later, women who attended centering are more likely to access family planning and show improved health literacy and health behaviors, factors that may be especially significant in our community for our teen clients. The budget for this new service line was calculated using individually billed visits. We will not be doing global fee for this service. We're estimating 120 clients in year number 1 and increasing to 150 in year number 2. These are based off of numbers of clients currently being taken in through the health department and our own clients at HCHC. 65% of our clients are Medicaid, and in the state of Virginia, APRNs are reimbursed at 100% of the rate of MDs, so that's very helpful. We also have a proportion of women who have commercial insurance and who are on our slide or our self-pay. We don't anticipate a lot of prenatal revenue from Medicare. We've also calculated some significant procedures such as postpartum LARC utilization and some common tests and vaccinations used in pregnancy. Centering utilization, we're expecting in years 1 and 2 to do 1 new group a month, but in year number 1, we're anticipating 6 clients per group, and in year 2, that'll increase to 10 clients per group. Women who cannot be seen in centering will be seen in individual visits. We plan to offer Spanish and English centering initially and consider Arabic as our service line grows. Our expenses were calculated because this is already a functioning clinic as a percentage of facility and staff utilization. We anticipate 3% utilization of the total center in year number 1 and 5% in year number 2. There is a significant personnel budget item in year number 2. We anticipate having to add a 0.5 CNM and 0.5 LPN in year number 2 to serve our growing clientele. This leads to a year 1 net loss of approximately $3,000, and in year number 2, an anticipated net loss of $10,000, mostly due to those new personnel. However, to offset this loss, I suggest that if the CNM hired in year number 2 does just 5 GYN visits per week, and if 65% of those are Medicaid, as is standard in our clinic, that would generate $23,000 of additional revenue, which would put this program into the black in year number 2. In summary, as the healthcare home to a large and diverse part of our community, HCHC is ready to add obstetric care with centering pregnancy. APRNs are well qualified to implement this program, which will address community needs by facilitating first trimester prenatal care, enhancing continuity of care, and improving postpartum follow-up and family planning. This program will also bring HCHC fully into compliance with HRSA recommendations and should become a source of revenue for the center by the end of year number 2. Thank you for your support. Here are my references. Okay.
Very impressive. Okay, that's a little intimidating for all the rest of you, right? You know.
No, don't forget it.
Yeah. And that was beautifully done. I mean, very compelling. You laid out your case, you know, for, you know, and how could somebody say no? After when we do our discussions, I want to find out from you all how many of you are actually seriously going to make these proposals, you know, and how many of you just did this to, you know, to be able to graduate. So we'll learn a little more from Anne about whether that they really are. I mean, she's so persuasive that my hunch is that they really are going to implement centering here. And you know, one of the things that I want to point out that Anne did is pulled in not only community needs, but institutional needs. So there is a clinic, an FQHC, that as part of their, if I understand this right, as part of their, you know, every couple year compliance evaluation, accreditation, whatever the body was, came in and said, you know, you're lacking in women's health services, so you need to do women's health services. So when you can meet the needs of the institution as well as your community, it makes it more persuasive. And then the other thing it does when you bring in an innovative program, you're selling not only yourself as a provider, but you're selling a model of care that has been demonstrated to have good outcomes, that then you match those with your community needs. You know, I think particularly those of you who are in the master's program, I mean, when you graduate, you just want a job, right? So, and that's totally understandable. So you may be approaching a new position, a practice, and say, create a position for me. And to just go at it with, I need a job, hire me, is not as compelling as it sounds self-serving, you know. So when you add something new, something innovative, something exciting like centering, it just makes it makes it bigger than you. So Anne did all that beautifully together. So nice job. Okay, you can mute yourself, take a deep breath, relax, and Brittany. Okay, so we can see you. So whenever you're ready, go ahead and start.
Okay. So hey everyone, my name is Brittany Sloan, and I would like to start at Heart Healthy Clinic in an existing family practice office in Charlotte, North Carolina. Charlotte is located in Mecklenburg County. The population of Mecklenburg County is 1,034,070, and a population of Charlotte is 827,097. Charlotte is in an urban city and takes up the majority of the county. Obesity, smoking, hypertension, hyperlipidemia, and diabetes are all unmet health needs in the community. Obesity is at 24%, smoking at 14%, 33% have high blood pressure, 41% have high cholesterol, and 9.3% of the population are diabetic. All of these are risk factors leading to cardiovascular disease, which is the leading cause of death along with cancer in Charlotte. That leads us to our community needs. My community needs I identified are uninsured population, preventative education, and routine screening. All of these needs can result in poor health outcomes if not addressed. 18% of the population is uninsured in comparison to 13% in the state and 11% nationally. Preventative education is desperately needed due to the high percentages of cardiovascular disease risk factors in the community. Smoking, obesity, diabetes, hypertension, and hyperlipidemia are all above the target goal percentage in the community, state, and nation. Routine screening is lagging due to many patients not having access to care, as well as not being educated on the importance of this screening. 31% of adults in Charlotte are without a primary care provider, 25% in the state, and 23.5% nationally. The program I have proposed addresses these needs through a heart healthy clinic within an existing practice. The Heart Healthy Clinic of Charlotte is a private professional program whose mission is to promote a healthier community by helping individuals prevent, treat, and manage cardiovascular disease. The program is a comprehensive approach to building a healthy lifestyle. It is designed to educate patients at risk for cardiovascular disease by addressing the physical, emotional, and mental needs of each patient through compassion and comprehensive health and human services, regardless of ability to pay. The Heart Healthy Clinic will be established as a partnership in an existing primary care practice in South Charlotte. The existing practice has 2 physicians and 1 nurse practitioner, and I would make the second FNP. The structure was chosen because all of the providers will use and benefit from the program. Therefore, there will be shared financial commitments and profits, including the additional staff within the office. Each partner contributes to all aspects of the business, including money, property, labor, and skill. My program will be available to any patient who has already had a heart attack, has coronary artery disease, or has risk factors for cardiovascular disease. This will be a billable service. The program will consist of an individualized nutrition plan, an exercise routine, management of medications, blood pressure, and glucose, and educational materials will be provided. Prior to each visit, I will have the patient have blood work done, so I will have the results before our appointment so we can see what adjustments need to be done to medications and our plan. Many patients also deal with a lot of stress and emotional needs, so I will also be able to sit down and talk with the patient if this is something they require. I know a lot of patients do not have access to a gym, which is why I have added treadmills and weights to the office. Any of the enrolled patients will be allowed to come exercise for free at the office. The program itself will be provided for all types of insurances as well as self-pay patients, which I will give them at a discounted rate. This leads us to revenue and expenses. My first year estimated having 1,846 visits. The revenue with procedures, labs, and types of visits based on Medicare and Medicaid fee schedules, commercial insurance reimbursement rates, and self-pay is estimated around $809,671.69. Expenses would be higher in the first year with the startup equipment of treadmills, weights, exam tables, chairs, cardiac monitoring equipment, and salaries at $523,831.41. This gives me a profit of $285,840.28. Since this is an existing practice, that eliminates any of the startup costs. As the years go on and more patients are seen, I imagine this program continue to grow and profit. In conclusion, the addition of a heart healthy clinic would benefit the community of Mecklenburg County by providing preventative care to patients at risk for cardiovascular disease. The individualized plan, continued monitoring, and educational materials will provide our patients with optimal health outcomes, in turn allowing me to address the community's unmet health needs. And these are my references.
Beautiful. Very, very nicely done and very persuasive. Okay, so I'm eager to find out if you're going to really propose this to this practice. So again, like Anne did, you're proposing adding a new program into an existing practice. And I'll be real curious to hear about. I mean, as you were going through it, it sounds so comprehensive and so lovely with exercise and counseling and nutrition and all that. I thought, oh my gosh, it's going to cost a fortune. You know, they're going to have to find this huge grant to be able to fund this for a few years. So, you know, that your calculations came up with it actually making a profit is impressive. And so
Right.
we'll get to look at that a little bit. So very nicely done. I really liked your slides, you know.
Thank you.
And did you create your own mission statement?
Yes, well, I did, but I reviewed other ones prior, but I didn't make it up.
Well, no, but yeah. So I think a nice thing to do. I mean, these days most organizations have a mission statement, and crafting that mission statement is sometimes people just steal others. But to do it well, it's take all the stakeholders and somebody facilitates it, and you put stickies everywhere, and it's this whole team building kind of exercise. So if you come into an existing practice, that's already been done. But if you're going to develop a new program or a new department or something, I think, creating a mission statement for that program is a really nice idea. It really, people roll their eyeballs about mission statements for understandable reasons, but they also truly can be a good tool. So I like the one that you did, so that's nice.
Thank you.
Okay. Mary Kay.
Can you hear me okay? My neighbor is blowing leaves right outside my window.
Doesn't that drive you crazy when they do that?
Can you hear?
Go talk to them before? No, I can't hear them at all. Really, I'm sorry. I shouldn't tease you. I can tell you're really nervous about this. We hear no leaf blowing.
All right. I am going to screen share, and let's see. All right. All right. I am Mary Kate Finnegan, and I will be presenting today on providing convenient care in Charlotte, North Carolina.
Mary Kate, why don't you stop and make sure we get it? Yeah, okay, now it is. Yeah, when you were first started talking, we could see your notes and everything, but now you're in the slideshow presentation mode, so that's perfect.
Okay.
So, okay, go ahead and start again.
All right. Well, I will be presenting on providing convenient care in Charlotte, North Carolina. Charlotte is the largest city in North Carolina with a population surpassing 827,000 people. The city has a dense population in the metropolitan area and is surrounded by a mostly suburban setting. Charlotte has a community need to expand culturally sensitive care to the multicultural population. Charlotte has a large Spanish-speaking population, and in the past 15 years, the Hispanic population has increased over 140%, and the number is projected to continue to grow. Hispanic residents are 27% more likely to live in poverty, and this creates both healthcare and socioeconomic deficits. Offering affordable services delivered by a staff fluent in Spanish will help to meet this community need. Charlotte also needs to work on prevention and treatment of sexually transmitted infections. Mecklenburg County's rate for STIs, specifically newly diagnosed cases of chlamydia, is 6,087 new cases per 100,000 people, and this rate is projected to worsen. A convenient, cost-effective opportunity for testing, diagnosis, and treatment will help to reduce these numbers and keep disease sequelae to a minimum. Charlotte also needs to increase the availability of free and/or low-cost clinics. The unemployment rate in Charlotte is marginally higher than that of the state and the nation, and the rate of uninsured adults is higher than the national average. This impacts care in several ways. Those who are unemployed are not eligible for healthcare benefits, and those who are uninsured are subject to often very high fees for wellness care and chronic disease management. Currently, Medicaid under the Affordable Care Act has not been expanded in North Carolina. As such, a large number of people cannot qualify for Medicaid, but also cannot afford monthly premiums and deductibles. This is a very large gap in our healthcare delivery system, which a lot of people fall into. And this is where affordable, fee-based convenient care clinics can help to fill that gap. To meet the healthcare needs of Charlotte, North Carolina, I propose opening Healthcare Within Reach, a fee-based healthcare clinic staffed by APRNs with convenient business hours. We will offer an alternative to insurance reimbursement and make the process of payment for services simple and efficient. Our mission statement incorporates the core competencies outlined by the National Organization of Nurse Practitioner Faculties. The mission of Healthcare Within Reach is to provide quality, evidence-based, and affordable care to the diverse people of Charlotte, North Carolina. We seek to collaborate with members of the community and build partnerships to improve health outcomes. Care will be individualized and collaborative in order to promote wellness and prevent disease. Our clinic will be opened using a general partnership business structure. An ideal startup will include at least 2 APRNs who will work together to open the clinic and share profits and losses, workload, and liability. A general partnership will be appropriate for this clinic as it will initially be small and owners can work together closely for patient care and business development. Increasing the number of owners will allow collaborative financial commitment and decrease the individual burden for funding startup. A general partnership offers both opportunities for growth and collaboration. When the clinic business begins to grow, the option will be available for other APRNs to join the partnership and increase the number of providers for the expanding client base. A collaborative practice agreement will be in effect according to North Carolina state requirements, and this physician can either be reimbursed by the APRNs or the option to become a partner in practice at the clinic would also be available to that physician. With initial business startup, a lack of profit is initially expected. It may be that APRN owners will not be able to compensate themselves according to their market value. Sharing workload and work hours will allow APRN owners to work part-time elsewhere, thus making the financial burden of business startup easier initially. Ancillary staff will be slim at first to reduce costs, but will be appropriate based on patient volume. Initially, an LPN will cover front desk as well as clinic tasks, but with growth, a medical receptionist will be hired in year 2 of business, allowing the LPN to perform clinic duties solely. Healthcare Within Reach will be a walk-in and by appointment fee-based clinic. The clinic will offer expanded convenient business hours to accommodate patients' schedules. The practice will not accept insurance. Patients having to pay directly to the clinic at the time of service will negate the need to hire an employee to code, bill, and attend to insurance needs, thus decreasing overhead costs. A set price will be assigned to visit types and be comparable to similar services offered at competing clinics. Contracts will be negotiated with a laboratory company as well as an imaging center to create a special price list available to patients of the clinic. This will be advantageous to all people, and for those insured, may prove cheaper than paying towards their deductible. The program plan at Healthcare Within Reach will address the needs of the community by providing a convenient, low-cost clinic to the insured and uninsured ages 12 months and beyond, employing Spanish-speaking providers to meet the needs of the large and growing Hispanic community, and offer convenient options for SDI testing and diagnosis. The clinic is projected to see 5,097 people in the first year. This number was figured based on the assumption that the practice will serve 10% of people in a 5-mile square radius of the clinic. The clinic is projected to serve 5,440 people in its second year, assuming a sales growth of 7.8%. For revenue projections, the clinic is expected to have a net revenue of $306,790 in the first year and $319,175 in the second year. This includes revenue from patient encounters, including exams, diagnostic testing, and medications. An initial business loan of $150,000 will be used to fund the business during the first and second year. Donations and contributions will be elicited from local philanthropists and community members. Expenses for the initial opening of Healthcare Within Reach will be approximately $301,164 for the first year and $313,913 for the second. Expenses include costs for equipment and personnel as well as various operating expenses. Healthcare Within Reach will make a small profit in the first year of $5,625 and $5,261 the second year. Things of note to factor into profit and loss include the outstanding business loan as well as APRN compensation. With a substantial business loan of $150,000 spread across the initial 2 years, the business stands to make a small profit during the first year. Reinvestment of profit into the business to pay these loans would help the business to become sustainable and financially stable. Compensation for the APRNs will be dependent on business growth. It would be up to the APRN owners if they'd be willing to sacrifice part of their salary to repay the business loan. In conclusion, Healthcare Within Reach strives to serve the diverse community of Charlotte and their healthcare needs by offering an affordable and convenient option for English and Spanish-speaking patients in order to improve health and strengthen the community. A fee-based structure for compensation offers uninsured and insured patients easy payment options and will reduce clinic initial startup expenses. The APRNs at Healthcare Within Reach will work with their patients to provide wellness care, treat illness, manage chronic conditions, and in turn will strengthen the community through improved health. And here are my references.
And you had 20 seconds left over.
My God.
Yeah, you were talking really fast.
I'm sorry.
It's okay. No, it's okay. I mean, you had a lot to say, and you're nervous, you know. And so, anyway, again, a very, very nicely done presentation, and very different from the first two that we heard, right? I mean, they were add programs to existing organizations. What Mary Kate's talking about is a classic small business model. Two entrepreneurs decide to go into business for themselves and identify a need and go for it and figure out, okay, what about loans and what about decreased compensation and having your front office person be also your back office person, you know, and then you grow as the practice grows. And and part of your persuasion.
I think I lost you. Did anyone else lose Catherine, or am I the only one?
No,
I did too.
you made her speechless.
Stop.
Yeah, I think she just got bounced off. Hopefully she can just connect here in a moment. Let's just give her a moment. I'm going to try texting her and just see if what's going on. Okay, so she's trying to text me back. She's calling IT. All of a sudden, I have no internet connection. Have never had this problem before. I'm asking her if we should take about a 10-minute break and just see. Yes, take 10 minutes and I will get back to you. So let's just all mute and turn off our cameras and take 10 and reconvene at 12:51. All right, sounds good.